late-breaking trial at the ESC, the post-PCI trial, which was presented at the European Society of Cardiology, which was subsequently presented in the New England Journal of Medicine in the issue of the same month. It remains undetermined whether the routine stress testing in high-risk patients who have undergone PCI results in changes in the subsequent management and preventive strategies like preemptive coronary revascularization or more aggressive medical therapy leading to a reduction in the major adverse cardiac events or death. Therefore, these authors designed a pragmatic trial comparing symptom-oriented versus routine stress testing in high-risk patients undergoing percutaneous coronary intervention post-PCI to determine the effect on clinical outcomes of a follow-up strategy that includes routine functional testing in high-risk individuals who have undergone PCI. So, more than 2,100 patients who have undergone PCI were assessed for eligibility. 447 were excluded. 1,706 underwent randomization. Now, if you look in first 12 months in the functional testing group, 12 died in less than 12 months and 18 died in less than 12 months in the standard care group, probably because of stent thrombosis. 723, that is 92.5% of the eligible patient underwent functional testing at 12 months according to the assigned strategy, and 9% of the eligible patient in the standard care group underwent functional testing at 12 months because of some clinical indications, and ultimately 949 were included in the final analysis in the functional group, and 857 were included in the final analysis in the standard care group. So what functional testing did they do? It was in the form of exercise echocardiography, exercise electrocardiography, nuclear stress testing, and stress echocardiography at 12 months. So if you look at the baseline characteristic, 80% of the patients were male at about age of 65 years with a body mass index of 25. And if you look at the high-risk characteristic, there were really very high-risk patients: left main disease, bifurcation disease, osteal lesions, CTOs, multivessel disease, more than 2 vessels stented, restenotic lesions. Diffuse long lesions were defined by length more than 30 millimeters and stent use more than 32 millimeters. There were bypass graft disease. There were high-risk clinical characteristics in the form of diabetes mellitus and the chronic kidney disease. If you look at the primary composite outcome, there was no significant difference in the standard care group versus functional testing. There was no significant difference in the death from any cause between the two groups, the functional testing group and the standard care group. There was no significant difference in the myocardial infarction in both the groups, and there was no significant difference in hospitalization for unstable angina in both the groups. So in this multi-centered pragmatic randomized trial for routine functional testing as compared with standard care for guiding follow-up strategies in the patients with high-risk anatomical or clinical characteristic who had undergone PCI, they found no significant between group difference in the primary composite outcome of death, myocardial infarction, hospitalization for unstable angina for 2 years. So the routine stress testing appeared to be associated with more frequent invasive coronary angiography and repeat revascularization after 1 year, which did not result in a significant reduction in major adverse cardiac events or mortality. So the researchers say that this result should be interpreted in context of previous findings from ischemia trial that showed no difference in the death or ischemic events with an initial invasive versus an initial conservative approach in patients with stable coronary artery disease and moderate to severe ischemia on stress testing. So what does it say? Both ischemia and post-PCI trials show the benefit of less is more concept. So if more invasive strategies or testing are performed less frequently, it will result in better patient outcomes. So although the characteristics of both the trials were different, both the trials say that conservative strategy is much better. There were limitations that it was not possible to mask the follow-up strategies of patients and investigators. There was non-adherence in the functional testing group. There were 3 different varieties of functional testing which were done. The trial did not address quality of life, cost effectiveness, and it was mainly represented by males. The women were underrepresented. There was an editorial in the same issue of New England Journal of Medicine by Thomas Holland, surveillance stress testing post PCI, future class 3 recommendations, and what she had to say. In an editorial accompanying the publication, she agrees that this new result would build on the findings from the ischemia trial. Collectively, this trial highlight the lack of benefit of routine stress testing in asymptomatic patients. She points out that many of the deaths in the trial, so I've shown you that there were deaths in 1 year, they were probably related to stent thrombosis, and therefore it would not have been prevented by routine testing at 1 year, and overall the event rates were quite low, most likely reflect the adherence to guideline recommendations in this trial. For example, 99% of the patients were receiving statins. So the post-PCI trial provides a compelling new evidence for a future class 3 recommendations for a routine surveillance testing after PCI. Until then, we must refrain from prescribing surveillance stress testing to our patients after PCI in the absence of other clinical signs or symptoms suggestive of stent failure. So I think it's extremely relevant. We all many times routinely do stress testing in asymptomatic individuals, so it's very relevant for a country where we could do away with unnecessary routine surveillance testing after 1 year. Thank you very much.